The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/DWV860. Downloadable slides and practice aids are also available.
Welcome to this educational activity, Teaming Up to Improve Liver Cancer Outcomes through Local, Regional, and Systemic Therapeutic Strategies, a multidisciplinary tumor board guiding optimal care for patients along the intermediate to advanced disease continuum. I'm Matt Johnson, an interventional radiologist at the Indiana University School of Medicine. I'm joined here with Dr. Amit Singhal, a hepatologist from UT Southwestern, and Dr. Richard Finn, a medical oncologist from the Geffen School of Medicine at UCLA.
Thanks, Matt.
Thanks. Good to be here.
Given that HCC often arises in the setting of underlying liver disease, expert input from different disciplines has become increasingly important in order to offer patients with HCC optimal care with individualized treatment plans. In this activity, you will hear our different perspectives as we review the standards of care as well as emerging therapeutic options from early to advanced HCC stages. Okay, the landscape in the treatment of hepatocellular cancer has really changed in the last few decades. Many years ago, when I first started practicing, there was not much to offer patients with advanced liver cancer. We did a lot of TACE, and we did a lot of times in a silo. Over the last 20 years, there have been major changes in what is available to interventional radiologists, but also to other physicians treating patients with hepatocellular cancer, most notably medical oncologists. The advent of Sorafenib was groundbreaking, and then for many years we worked between local regional therapies like ablation and TACE, and soon thereafter TARE or radioembolization. But then a new set of drugs came on the scene, and over the course of the last 3 or 4 years it has really exploded into drugs and agents with a lot of promise. And working together, trying to figure out the best way to treat patients using combinations of local regional therapies, surgical therapies, and the various oncologic agents has really made the field extremely interesting to work in and very exciting, because we have a lot more to offer our patients. And so that's what we're talking about today. And I've been asked to mention COVID and its effect upon us and effect upon this field. The major effect is that we're all sitting in our homes talking to you, and also that we have had to change the way we practice taking care of our patients in trying to do the best we can in an epidemic. And how does that affect patients who come to the hospital with cancer or other immunologic problems, and then trying to deal with it at the same time? So that has been a big deal. We're not going to stress it. For those of you who have access to the SIR website, there is a very good COVID toolkit, and I would bet there are similar toolkits available in hepatology and medical oncology. With that, then, I will send the podium over to Amit to talk about hepatocellular cancer and how it relates to underlying liver disease.
Thanks, Matt. So as you heard, I'm really going to be focusing on some basic epidemiology for HCC, as well as treatment options that we have in the early and intermediate stages. So to start, HCC is the 4th leading cause of cancer-related death worldwide. When you take a look from a global perspective, we know that the highest incidence and mortality rates reside in East Asia and in Africa, and it has an intermediate incidence and mortality here in the United States. But what's been of concern is that over the last 15 years, we've seen a rapid increase in HCC-related mortality. In fact, over the last 15 years, assessed by SEER, we see that the mortality for most cancers is nicely declining, related to improvements in early detection as well as treatment options. But over the same time period, we see that the mortality for liver cancer is rapidly rising and is actually much higher than the other common causes of cancer death in the United States. If these trends continue, it's projected that HCC could become the 3rd leading cause of cancer death here in the United States. When we take a look among subgroups, we see that the incidence and mortality is projected to increase in nearly all subgroups, both men and women, and once again in whites, Hispanics, and blacks. Taking a look at these groups, you can see that the incidence and mortality is expected to decline in Asians related to advances in hepatitis B vaccination programs globally, as well as hepatitis B treatment programs here in the United States, but is expected to increase in all other racial ethnic groups, largely related to increases in NASH and in an aging cohort of patients with advanced hepatitis C. One of the unique things about HCC is that the majority of cases happen in the setting of chronic liver disease and typically in the setting of cirrhosis. So patients can develop chronic liver disease from a host of different etiologies, including hepatitis B, hepatitis C, alcohol, and non-alcoholic steatohepatitis. This develops cirrhosis over a period of 10 to 30 years. And once a patient develops cirrhosis, they have an annual risk of HCC somewhere between 1 and 4%. There are some patients who can bypass the cirrhosis step and develop HCC in the setting of chronic liver disease, but this is relatively uncommon. And this really does, as we'll talk about, impact treatment options because HCC is uniquely a disease within a disease. And so for every treatment option that we consider, we also have to consider the underlying liver disease severity. As I briefly mentioned, there's many different etiologies that can lead to cirrhosis and HCC, and we've seen a shift in epidemiology over the last 10 to 15 years. Historically, hepatitis C has been the most common cause of cirrhosis and HCC in the Western world, in the United States and in Europe. But with the wide availability of direct-acting antivirals, we've actually seen that many of our hepatitis C patients have been successfully treated, and the risk of HCC has actually been mitigated, although not eliminated. In parallel, we've seen epidemics of obesity and diabetes, and we've seen many more patients develop NASH. In the United States, it's expected that actually up to 1/3, if not higher, of Americans will have some degree of non-alcoholic fatty liver disease. As the world becomes more obese and more diabetic over time, actually the incidence of NASH is only anticipated to increase further worldwide, and in parallel, it's expected that the incidence of NASH-related HCC will also increase. When we think of HCC treatment options and staging, we actually don't just consider the tumor burden, but we also consider the degree of liver dysfunction and patient performance status. The Barcelona Clinic Liver Cancer Staging System, the most widely used staging system worldwide, incorporates all three of these factors when staging HCC. And as you can see here, the BCLC then classifies patients into different stages ranging from very early or early stage to intermediate stage, advanced stage, and finally terminal stage. The BCLC is uniquely linked to treatment recommendations that once again range from curative treatment options including ablation, resection, and transplantation for early stage disease, locoregional therapy options for intermediate stage disease, and systemic therapy options for advanced stage disease. In parallel, you can see that these stages are associated with marked differences in prognosis, from greater than 5 years for early stage all the way to about 1 to maybe 2 years now for patients with more advanced stages of disease. Of course, treatment options, as we'll talk about in the cases later during the presentation, are much more complicated than simply drawing a line down to the treatment recommendation, but this does provide a nice starting point in terms of recommendations to start in clinical practice. The other complexity that the BCLC fails to really incorporate in a static image is the fact that patients migrate, so they can actually have progression when they start on a certain therapy and therefore need to go to another therapy as the tumor progresses, or they may have responses and downstage to more aggressive treatment options along their course. So going through some of the curative treatment options we have, the first is hepatic resection. And so surgical resection has historically been limited to patients who have a single nodule of any size in the absence of portal hypertension. So this surgical resection is the treatment of choice in non-cirrhotic patients, but also should be the first treatment that can be considered in patients who have cirrhosis without significant portal hypertension. Here in the US, most centers assess portal hypertension, in this case non-invasively, so taking a look at surrogate measures such as platelet count being greater than 100,000, normal spleen size and the lack of varices, either on endoscopy or on imaging. And in these well-selected patients, overall survival is very high and actually is somewhere around 60 to 70%. One of the limitations of surgical resection is that you do leave behind the rest of the cirrhotic liver, and therefore the recurrence rate is very high, and actually in many studies as high as 70% within 5 years. And therefore, after resection, careful surveillance is recommended to find these recurrent tumors at an early stage. I will say over time, we have become more aggressive with surgical resection, and in high volume centers, there are surgeons who can consider doing surgical resection either in patients with limited multifocal disease or in patients with limited portal hypertension, but the risk of complications and the risk of mortality is slightly higher in these patients. Liver transplantation is another curative option, and in many centers is regarded as quote-unquote the best treatment option for HCC, because this is regarded as a cure for both the cirrhosis as well as the HCC. Further, it's associated with the lowest risk of long-term recurrence, and so recurrence after transplant is exceedingly low, at 10% or less in expert centers. Historically, transplantation has been limited to patients within Milan criteria, so 1 lesion less than 5 centimeters, or 2 to 3 lesions, each less than 3 centimeters in the absence of vascular invasion or distant metastases. And this has been, once again, associated with very high survival, around 70%. Given these excellent outcomes, there has been interest in extending transplant to other patients, and so there have been many centers that have proposed either extended criteria or the concept of downstaging. Once again, patients who present with larger tumor burden are treated typically with locoregional therapies and then come to within Milan criteria. These patients are presumed to have good tumor biology, and retrospective data have suggested that these patients can have equally good post-transplant survival and low recurrence risk as those patients who initially started within Milan criteria. Accordingly, the transplant criteria for HCC has been expanded in the United States, and so now UNOS has actually incorporated downstaging criteria into their typical exception point protocol. So patients who present with 1 lesion greater than 5 centimeters but smaller than 8 centimeters, 2 to 3 lesions each less than 5 centimeters and a total diameter less than 8 centimeters, or 4 to 5 lesions each less than 3 centimeters and a total diameter less than 8 centimeters. If these patients are treated with locoregional therapy, downstage to within Milan, these patients can similarly receive MELD exception points and therefore receive priority for liver transplantation. And this has become standard across transplant centers here in the United States. Now, while these therapies are associated with very high survival and should be pursued whenever possible, unfortunately, only a small minority of patients are eligible for these surgical therapies. And therefore, locoregional therapy, as Matt said, really plays a large role in the clinical management of patients with HCC. And actually, when you take a look at this either in the United States or globally, locoregional therapy continues to be the most common therapy for HCC. Accordingly, the AASLD and ILCA both recommend locoregional therapy as being the primary modality for patients who are not eligible for surgical resection or liver transplantation. There has been a systematic review that's compared the different locoregional therapy options, which, as Matt has already talked about, is expanding to beyond TACE to now include other things like bland embolization and radioembolization. And there really are no strong data to suggest one locoregional therapy over another. In terms of direct comparisons, I think most of us are aware that there are retrospective data comparing chemoembolization and radioembolization, as well as a small randomized control trial. And these data consistently show that time to progression may be longer with radioembolization, although there's not a survival benefit with one modality over another, as best we can tell with current data. There's been increasing recognition that there's heterogeneity within BCLC stage B and those patients who undergo chemoembolization. There have been several prognostic scores that have been proposed, one of which is the 6 and 12 prognostic score for patients undergoing TACE. This score initially came out of Asia and has been since validated in cohorts from Europe, but simply divides people into 3 different categories based on the sum of tumor diameter plus the number of lesions, and categorizing people as 6 or less, between 6 and 12, and those patients with the sum being greater than 12. And as you can see here, the prognosis is marked different between those 3 categories, with a median survival of around 49 months for those patients with a score less than 6, to a median survival of around 16 months for those patients with a score greater than 12. These scores are largely just prognostic at this time, but there are some who believe that this can help in terms of determining which patients among BCLCB patients should be instead treated with systemic therapy instead of locoregional therapy. But these data are still coming out. Finally, you can tell from the whirlwind of treatment options that we just went through that there are many different providers who are involved in the care of HCC patients, including hepatology, transplant and surgery and surgical oncologists, interventional radiology, and medical oncology. And really, to observe the best outcomes and to determine the best treatment for any individual patient, this requires careful communication between all of these different groups. And therefore, there have been several studies that have demonstrated the benefit of multidisciplinary care for the management of HCC, including several studies that have shown improved treatment delivery and improved overall survival. And therefore, many of us consider multidisciplinary care now to be the standard of care for the management of HCC. In summary, the incidence and mortality of HCC is increasing worldwide, and we've seen a shift from viral etiologies to NASH etiologies. And there are considerations in terms of surveillance that go along with this shift in epidemiology. Patients with early-stage HCC should be considered for potential curative therapies, including surgical resection, liver transplantation, and local ablation. Clearly, locoregional therapy continues to play an important role for the management of HCC, including bridging to liver transplantation, downstaging some patients with larger stage disease to liver transplantation, and of course, treatment of patients with intermediate stage disease. And finally, multidisciplinary care is critical, has been shown to improve overall survival, and is largely considered to be standard of care for the management of patients with HCC. Now that we've covered the treatment options for early and intermediate stage HCC, we will hear from Rich about the exciting advances in the area of advanced HCC treatment options.
Thank you very much, Amit, for that excellent presentation. And I'd like to thank PeerView for the opportunity to be part of this program, and thank you all for joining us today. As you heard from Dr. Johnson at the beginning of the program, that for many years we did not have any drugs that were proven to improve survival for advanced liver cancer. That changed in 2008 with the SHARP study. This was a hallmark study published in the New England Journal of Medicine that looked at the multi-kinase inhibitor Sorafenib versus placebo in a double-blind placebo-controlled study. And this study was a landmark, and that was the first time that we saw an improvement in overall survival with a systemic agent for advanced liver cancer. As you can see here, median survival was improved by about 3 months, but importantly, the hazard ratio was 0.69, which represented a 31% decrease in the risk of death. Also, from this study, we learned some important things about this new age of targeted therapeutics. Importantly, that we could improve survival without inducing a response rate. Importantly, Sorafenib delayed progression and therefore improved overall survival, keeping in mind that in any cancer medicine study, our ultimate goal is to improve overall survival. Now, Sorafenib does have some side effects, and we'll talk about that repeatedly throughout the program today, the side effects with our new drugs, but generally they were manageable. It's a VEGF receptor inhibitor, and therefore hypertension can be seen, but also fatigue, GI toxicity, specifically diarrhea, and also a hand-foot skin syndrome, HFSR, which generally can be managed as well, either with supportive care measures such as topicals, or dose reductions or delays as needed. Now, in 2008, we were all very excited by this new data set, and we all really expected a new era of new drugs for the treatment of liver cancer. and we were hopeful to see new drugs that were better than Sorafenib, as well as regimens that had activity when Sorafenib stopped working. But as many of you are aware, we had about a decade of negative studies. Numerous phase 3 studies of promising new agents failed to meet their endpoints in phase 3 study. Now, in the frontline setting, the first positive study we had was the REFLECT study. This was in 2018, about 10 years after Sorafenib's approval. And this was an open-label, randomized study of Lenvatinib versus Sorafenib in the frontline setting. And when we're talking about frontline advanced liver cancer, we're typically talking about patients who have Barcelona stage C liver cancer, or those with Barcelona B, which is intermediate stage, but have progressed after locoregional therapy. Keep in mind that if patients do not undergo transplant or some other curative approach, and they do not die of complications of cirrhosis or some other cause, patients will stage migrate, meaning that they will maybe start with intermediate stage disease, receive several rounds of locoregional treatment, and then become refractory to locoregional treatment or progress with disease into the vasculature or extrahepatic spread. Those are patients who would be considered appropriate for systemic treatment. As you can see in this study, this was a global study that took patients who were generally Child-Pugh A, and again, that is another common theme in our systemic studies, that by choosing patients who have Child-Pugh A liver disease, we minimize the risk of death from underlying cirrhosis. These patients uniquely in the REFLECT study were excluded if they had main portal vein invasion, that is, portal vein invasion outside of the liver, or VP4, or if they had an extremely large tumor burden with over 50% of their liver occupied by tumor or clear bile duct invasion. Now, Lenvatinib is a little different from Sorafenib. Similarly, it is oral and it is a VEGF receptor multikinase inhibitor. It does have some activity against different kinases, specifically the fibroblast growth factor receptor family, and it is dosed by weight. Lenvatinib is currently approved in kidney cancer and thyroid cancer, where it is dosed differently. But in the setting of patients with underlying liver disease, it is dosed based on body weight, 12 milligrams if you're over 60 kilos, or 8 milligrams if you're under 60 kilos. The primary endpoint in the study was overall survival, and importantly, it was powered to show non-inferiority. You can see here Lenvatinib had a survival of 13.6 months, Sorafenib 12.3 months, and the hazard ratio was 0.92. Importantly, the confidence interval on the hazard ratio for survival met the non-inferiority threshold. That is to say, the upper limit was less than 1.08, and here you see 1.06. So this study met its endpoint of non-inferiority to Sorafenib. What does non-inferiority mean? Well, it means that the drug is really no better for its endpoint, and it also means that we might accept it even being a little worse. As you can see, the hazard ratio is above 1. But at the end of the day, we see it was 0.92, and this did not meet superiority, but was the basis for the approval of Lenvatinib in the frontline setting, giving our patients another option for management of their disease. Now, interestingly, when we look at secondary endpoints, we see that Lenvatinib was superior to Sorafenib. Here, looking at progression-free survival by modified RECIST criteria. And those in a radiology audience are very familiar with RECIST criteria, where we measure the sum of the longest diameters. However, we've seen with novel targeted agents like Sorafenib and Lenvatinib and others that you can lose the enhancement of HCC tumors in the liver without necessarily shrinking the total diameter. So modified RECIST was created to capture this biological effect on liver tumors with unique vascular characteristics. So modified RECIST looks at the sum of the enhancing component. Not too much different to how we assess response in the setting of chemoembolization. Here you can see that median PFS was essentially doubled with Lenvatinib from 3.7 months to 7.4 months with Sorafenib and Lenvatinib respectively, and this translated to a hazard ratio of 0.66. Now, on the next two slides, we'll be looking at an independent review performed by Riccardo Lencioni of the patients in the REFLECT study. Here you can see the modified RECIST response by investigator was 24%. By independent review, that was 40.6%, which is obviously quite higher, and I think refers to the fact that modified RECIST is not always appropriately applied in the community setting. And then you have the RECIST 1.1, the conventional RECIST, and here what was very interesting, we saw a response rate of just about 19%. Keeping in mind that with Sorafenib, historically responses were single digit by conventional RECIST. And along those lines, here you see the independent review by Sorafenib. Now, mRECIST numbers are typically always higher than the RECIST numbers. And you can see here, again, investigator and independent review responses by Sorafenib using mRECIST was 9.2 and 12.4%, and by RECIST criteria, 6.5%. So Lenvatinib appears to have a higher response rate and a higher ability to delay progression, but still overall survival was fairly similar. There are some different side effect profiles we keep in mind when considering these two drugs. Lenvatinib is a very potent VEGF receptor inhibitor, and therefore we see a higher grade and incidence of hypertension. And differentiating it from Sorafenib is the incidence of hand-foot syndrome is somewhat decreased, more frequent and higher grade with Sorafenib as compared to Lenvatinib. These are two things we might keep in mind when trying to choose which agent we will use first line for any given patient. In common, they both cause anorexia and weight loss, as well as diarrhea. And also relating to its VEGF receptor inhibition, Lenvatinib has a higher degree of proteinuria, which we need to monitor while patients are receiving treatment. Before we move on to second-line agents, I want to note that recently the combination of Atezolizumab plus Bevacizumab was FDA approved in the frontline setting. We will discuss the results later in this presentation. Now, really, in the last 2 years, there's been an explosion of new approvals in second line. And this is an important thing to keep in mind as we have new drugs approved. We've had a lot of progress in liver cancer, and it's up to us as clinicians to figure out how best to integrate this new data into our treatment landscape. And here you see a high-level summary with the hazard ratios with Regorafenib and Cabozantinib, both two small molecules, very similar results, as well as Ramucirumab, that again, by the hazard ratio is very similar. And there were some common inclusion criteria throughout all these studies, including Child-Pugh A, liver disease, as well as Barcelona B or C staging. However, the Regorafenib experience required patients who have tolerated a minimal period of Sorafenib, and they had to have documented radiographic progression. The Cabozantinib phase 3 study took patients who were intolerant to Sorafenib, as well as those who had radiographic progression, and also had about 25% of patients who had a third line, received Cabozantinib as their third line option. And Ramucirumab, which is a monoclonal antibody to the VEGF receptor, required that patients had a baseline AFP of greater than 400. And this came from a retrospective analysis of the first REACH study, which, while negative overall, identified this subgroup of patients who had an elevated AFP as those who potentially get a greater benefit. And therefore, the REACH2 study enrolled patients with this elevated biomarker. And again, you can see the efficacy signals here are fairly similar. Certainly with the Regorafenib and Cabozantinib studies, the magnitude of benefit and the absolute delta was very similar. The control arms behaved very similar. The Ramucirumab study concentrated on this high AFP group, which we know is a worse prognostic sign. And this group, in the combined analysis of REACH1 and REACH2, had a survival of 5 months in the control arm and increased to 8.1. Now, both Regorafenib and Cabozantinib have very similar side effect profiles, and in that regard, similar to Lenvatinib and Sorafenib, as these are all multi-tyrosine kinase inhibitors. Ramucirumab is a monoclonal antibody, so most of its side effects, essentially all of them, can be tied to its VEGF inhibition, and therefore we don't see as much diarrhea, we don't see hand-foot skin syndrome, we do see more vascular events such as hypertension or proteinuria and some increase in ascites. Both regorafenib and cabozantinib are oral. Regorafenib is dosed 3 weeks on and 1 week off. Cabozantinib is continuous, and ramucirumab is an intravenous infusion given every 2 weeks. And we now have several immuno-oncology agents. These are generally monoclonal antibodies that activate the immune system to attack tumors. We'll now walk through the data from these individual studies. Here we see the data that supported the accelerated approval of Nivolumab. Now, the CheckMate 040 study was essentially a very large initial phase 1/2 study, initially defining the safety of single-agent Nivolumab in liver cancer, and has subsequently been expanded on to several different arms in a fairly efficient clinical trial design. Initially, there was a dose finding phase, looking to make sure that Nivolumab was safe in patients who had various etiologies of liver cancer, those that are uninfected, hepatitis C infected, or hepatitis B infected. And then there was an expansion phase in all of these etiologies. And the reason for that is that by the time Nivolumab entered the liver cancer space, there was a very good understanding of its side effect profile. Now, the PD-1 inhibitors are generally very safe and effective in many malignancies. However, because of their unique mechanism of action, that is to say, it activates the immune system to attack the cancer, the most common serious events we see are those related to autoimmune phenomena. And really, it's very hard to predict what will happen to any given patient or the severity or which organ could be affected. In reality, any organ system can be affected, and the literature is full of fairly unusual autoimmune effects, including those in the CNS or the heart. But more commonly, we'll see thyroid, hyper or hypothyroidism, as well as things like rash or colitis to various degrees. But also autoimmune hepatitis can be seen, and that was one of the main concerns for patients with cirrhosis. As you can see on this slide, though it's fairly busy, the take-home message is there were really no new side effects seen with Nivolumab in patients with underlying liver disease or hepatocellular carcinoma, as well as the incidence of significant liver events were fairly uncommon, and the drug is actually very safe in this population. Now, what was striking with Nivolumab is that patients who received this agent, many of them had very durable responses. Keep in mind, until this new age of checkpoint inhibitors, the TKIs were improving survival, but with fairly low response rates. And the initial approval of Nivolumab was based on phase 2 data that showed an overall response rate of around 15% in the expansion phase, and these were very durable. And the responses were very consistent throughout the different etiologies of liver cancer. Now, part of the accelerated approval mechanism required a commitment to do a phase 3 study, and last year we saw the results of CheckMate 459, which was the confirmatory phase 3 study. This was a frontline study of Nivolumab versus Sorafenib, and unfortunately this study did not meet its primary endpoint of improving overall survival. The hazard ratio was 0.85 with a p-value of 0.07. Now, some things to note here is the response rate with Nivolumab in the frontline setting was again about 15%, so that confirmed the phase 1/2 study. These responses were very durable, as in the earlier phase study. Nivolumab had a survival of 16.4 months, which is the longest survival we've seen in an advanced liver cancer study at the time. And Sorafenib had a survival of 14.7 months. Again, the longest survival we've seen with Sorafenib in a phase 3 study, quite different than what we saw in the SHARP study in 2008. Now, if you look at progression-free survival, again, the median was not improved. It did not meet its endpoint. But what we saw, as we've seen in other studies with checkpoint inhibitors, is that there's a subgroup of patients that just don't progress, and that this tail of the curve tends to exist for some period of time. So as we can see in this data set, as with other checkpoint inhibitors that there seems to be a subset of patients that get long-term disease control. Here you can see with Nivolumab, 14% of patients are progression-free at 2 years, and with Sorafenib, only 6%. Similarly, Pembrolizumab, another PD-1 monoclonal antibody, received accelerated approval for the treatment of advanced HCC in the second-line setting. This was based on the results of the KEYNOTE-224 study, which was an open-label, single-arm study looking at the safety and efficacy of Pembrolizumab in an advanced population. The objective response rate with Pembrolizumab, the duration of response, and side effect profile was very similar to what we saw with Nivolumab in a similar population of patients. That is, patients who are Child-Pugh A, who are intolerant or having progression on Sorafenib. Here we see the response data for the KEYNOTE-224 study. The objective response rate was 17%, and the median duration of response was not reached at the time of the primary analysis. You can see here the swimmer's plot for those patients who had responses, and many of them are very long-lasting, and typically these occur fairly early into the start of treatment. Here you see a Kaplan-Meier curve of the patients who've had a response, and again you can see very long, durable responses for those patients. The adverse events seen with Pembrolizumab are very similar to those seen with Nivolumab and other checkpoint inhibitors. While serious adverse events are fairly uncommon, specifically we did not see autoimmune hepatitis, one of the main concerns with the use of these drugs. More commonly, we did see fatigue, rash, itching, and diarrhea, but these were typically low grade. It should be kept in mind that with all of the checkpoint inhibitors, serious adverse events can occur, and we need to be cognizant of that because treatment may include steroids or other immunosuppressive treatments. But again, these are generally uncommon from what we've seen in the checkpoint studies in liver cancer. Now, unlike the strategy taken with Nivolumab, where the pivotal phase 3 study was a frontline study, in KEYNOTE-240, this was a phase 3 study of Pembrolizumab versus best supportive care and placebo for second-line therapy. And in this study, patients were randomized between Pembrolizumab or placebo in a 2-to-1 fashion that was blinded. Now, as you can see here, the median survival for Pembrolizumab was 13.9 months, the longest survival we've seen in a second-line study. And similarly, placebo had a survival of 10.6 months, which was the longest survival for a placebo-controlled study for the placebo arm. That translated to a hazard ratio of 0.781, and you can see the upper limit of the confidence interval was less than 1, and the p-value was 0.0238. However, despite a 22% decrease in the risk of death, this study cannot claim to show superiority of Pembrolizumab versus placebo because based on the statistical plan, we had to have a p-value of 0.0174, which obviously was not reached. So technically, this is a negative study. However, I think many of us look at this data set as well as the combined data with Nivolumab and feel that checkpoint inhibitors clearly have a role in the treatment of advanced liver cancer, certainly in the second-line setting. Now, in the past few months, we've seen some very exciting new data with immunotherapy agents in advanced liver cancer that makes the timing of our presentation very topical. Now, as we've commented, with single-agent PD-1 inhibitors, response rates are generally around 15 to 20%. And our feeling is if we could improve that response rate, then certainly we could improve survival. Now, in personalized medicine, ideally we could have a biomarker that tells us who those patients are that respond to the PD-1, PD-L1 inhibitors. However, it's been very difficult to identify any single biomarker. There are some interesting leads, I would say, but those are not yet validated. So another approach would be, could we just increase the overall response rate by combining PD-1 inhibitors with other agents? And there's been several things put forward. One, targeting the VEGF axis, either with monoclonal antibodies or small molecules, seems to change the microenvironment and increase responses to checkpoint inhibitors. Similarly, targeting other checkpoint pathways such as CTLA-4 with drugs like Tremelimumab or Ipilimumab is another strategy. Here we see the results of CheckMate 040 looking at 3 different dosing regimens. There was no control arm in this study, but about 50 patients per arm received different dosing regimens of Nivolumab and Ipilimumab with different frequencies. As you can see, they all gave very similar response rates of about 30%, and many of these were very durable responses. The median time to response was about 2 months, and the duration of response was quite long, with many of them up over 3 years. But the median was around anywhere from 15 to 20%. However, the survival for Arm A did seem a little longer than the other 2 arms, and therefore that was the regimen that received FDA approval. You can see here survival in this second-line population was about 23 months. And again, quite striking data. Based on this, a phase 3 study has been launched in the front line of the combination of Ipilimumab and Nivolumab versus a first-line TKI such as Sorafenib or Lenvatinib. Now, toxicity with this combination was higher than single-agent Nivolumab, and we've known that from other studies in other diseases when you combine these 2 drugs. Again, the common side effects were rash or endocrine, such as hypo or hyperthyroidism. There was an increase in grade 3-4 hepatic events, such as elevated liver enzymes, and notably, about half the patients in Arm A, which was the group that was selected to move forward, needed corticosteroids to treat certain adverse events. So while this regimen looks very exciting and now has FDA approval, it needs to be considered in light of some of the side effects about which patients we offer this to. The other strategy I mentioned was targeting the VEGF axis in combination with checkpoint inhibitors. We know that targeting VEGF has been of interest in liver cancer for some time because liver cancer is a hypervascular tumor. Its hypervascularity is the basis for locoregional treatment. Inhibiting the VEGF axis can be done very effectively with our small molecules as well as monoclonal antibodies. Focusing on Bevacizumab, which is a monoclonal antibody to VEGF, which was really the first anti-VEGF therapy approved in cancer medicine, affects the tumor vasculature by blocking VEGF binding to its VEGF receptor. And our understanding of the effects of VEGF inhibition have evolved over time. Initially, this idea of just starving a tumor of a blood supply, but we now know that downstream effects of that can affect the immune microenvironment and affect the different types of T cells in that environment, as well as antigen-presenting cells, and things that can activate T cells at the end of the day. So the Imbrave 150 study was a phase 3 open-label study of Atezolizumab, which is a PD-L1 inhibitor, plus Bevacizumab versus Sorafenib in the frontline setting. This study was similar to all the other frontline setting studies that have been done in advanced liver cancer, taking patients who were Child-Pugh A, had Barcelona B or C liver cancer. Importantly, because Bevacizumab is a very potent anti-VEGF therapy, patients were required to have an EGD within 6 months to make sure they did not have varices that were at high risk for bleeding. The primary endpoint of this study was both progression-free survival and overall survival. This study read out in the fall of 2019 and was published in New England Journal of Medicine in May of 2020. And here you see the primary endpoint of progression-free survival, which was significantly improved with the combination. Here you see Sorafenib had a PFS of 4.3 months, and this was improved to 6.8 months. This was a hazard ratio of 0.59, or a 41% decrease in the risk of progression with the use of the combination. Most importantly, this was the first frontline study that has improved overall survival as compared to Sorafenib in more than a decade. Here you see Sorafenib had a survival of 13.2 months, a very typical survival for Sorafenib in modern age studies. And at this time of the primary analysis, with a median follow-up of just over 8 months, we have still not reached the median survival with Atezolizumab and Bevacizumab. However, the hazard ratio for death is 0.58. This is a 42% decrease in the risk of death with the combination as compared to Sorafenib. You can see here, looking at some benchmark survivals, that at 6 months, 85% of patients that are receiving Atezolizumab and Bevacizumab are alive versus 72% in the Sorafenib arm. And if we go out to a year, that separation stays stable, and we will be looking forward to an updated survival set at some time in the future. Based on these results, the study was declared to be positive, and the combination regimen of Atezolizumab plus Bevacizumab was recently FDA approved in the first-line setting. Now, like we've seen with other checkpoint inhibitors, we see a significant and durable response with this combination. And quite striking, the objective RECIST response rate was 27% with the combination and 12% with Sorafenib. Interestingly, this was the first time we've seen a double-digit RECIST response rate with Sorafenib in any phase 3 study. Those numbers are increased somewhat with modified RECIST, but again, we see about 6% of patients in the combination arm having a complete response, and the remainder of patients having partial responses that were quite durable. We still have not reached the median duration of response with the combination, and we can see at the time of this analysis, 87% of patients had an ongoing response. The safety profile from the Imbrave 150 study did not reveal any new safety signals for the combination. Common side effects we saw with Bevacizumab included hypertension, as well as proteinuria, things that we're very familiar with. And similarly with Atezolizumab, there were no new side effect profiles, with those generally being low grade, again related to its autoimmune effect or infusion reactions. Here you see the side effects with Sorafenib in this study were generally similar to what had been described in the past. And what was very striking is that it appears that the incidence and severity of side effects seem to be worse with Sorafenib than with the combination arm. And so what we see here is that we are getting in the Imbrave 150 study synergistic efficacy without synergistic toxicity. Now, there are other novel combinations being evaluated. Tremelimumab, which is another CTLA-4 monoclonal antibody, is being studied in combination with Durvalumab. This is a PD-L1 antibody, and there was an initial phase 1 and then a larger phase 2 study looking at this combination in various doses, as well as comparing it to the single agents to see the relative contribution. Updated data from this study was presented at the ASCO 2020 meeting. Here we can see that there is an increase in side effects with the combination as compared to the single agent, and that does seem to be related to the dosing study of Tremelimumab. High dose versus lower dose, there is an increased frequency of adverse events, and again, typically we're seeing the autoimmune type of events that we've seen with the other checkpoint inhibitors. And what you can see here also in this second line study, that median overall survival was quite impressive with 19 months in the combination arm, and overall responses were quite higher in the combination arm. Here we see 23%, and still the median duration of response had not been reached. Based on these data, the phase 3 Himalaya study has been conducted looking at Tremelimumab and Durvalumab versus Sorafenib. The other combination that is looking very promising in liver cancer is that of Lenvatinib and Pembrolizumab. Combining the VEGF receptor and multikinase inhibitor with Lenvatinib and Pembrolizumab has been looked at in an initial phase 1 study for safety and then an expansion study. And this study has led to a phase 3 trial, the LEAP-002 study. An updated data set from the phase 1b expansion arm was presented at ASCO, and these data look very exciting. On this slide, you see the different response readouts by independent review, modified RECIST, independent review RECIST, and mRECIST. And you can see again, these are very high numbers, 46% by MRECIST, 36% by conventional RECIST, and 41% by investigator modified RECIST assessment. And PFS was quite long in the 8 to 9 month range. Again, we see side effects from Lenvatinib as well as those from Pembrolizumab, but nothing new from the combination. Now the results from the phase 3 study are eagerly awaited. So there are a number of ongoing phase 3 studies. Some have read out that we spoke about, the CheckMate 459 study, Imbrave 150, and then ongoing studies such as Himalaya, which is Durvalumab and Tremelimumab versus Sorafenib. Cosmic 312 is looking at Atezolizumab and Cabozantinib, which we spoke about as being approved in the second-line setting as a single agent, but now looking at the combination. We really have not seen much early data from this combination, but I think it's fair to say that it is building on the data with Pembrolizumab and other VEGF inhibitors. The LEAP-002 study, we're waiting for results. That study completed accrual, and that's Pembrolizumab and Lenvatinib versus Lenvatinib. And most recently, the CheckMate 90W study was launched looking at Nivolumab and Ipilimumab, a combination currently approved in second line, but now in a phase 3 study in front line. And if we look at the updated NCCN guidelines, they have really incorporated all of these updated data into treatment options, also including now the combination of Atezolizumab and Bevacizumab. So we've come a far way since 2008. While we had a long period of numerous phase 3 failures, since 2018, we've really been on a roll, I would say, and we've now markedly improved overall survival in the frontline setting with our patients with advanced liver cancer. And I think one of the key messages is that now that we have such active drugs in advanced liver cancer, it really behooves us to continue to work as a team. That as patients become refractory to TACE, it is important that we transition them to systemic treatment before they decompensate. In the past, before we had active systemic agents, it might have made sense that for patients who continue to develop new lesions or regrowth of a prior treated lesion after TACE or Y90, that maybe we would try again with one of these local regional treatments. But I think we now have such high-level evidence from large randomized studies that show we're improving survival, we really need to work with our hepatologists and oncologists to transition patients back to systemic treatment when appropriate. So with that closing thought, I'd like to transition it back to Dr. Johnson to lead us through some very interesting cases that highlight the multidisciplinary care of patients with liver cancer. Thank you.
Thanks, Rich. That was excellent, and as always. And I'm just going to show a couple of cases and try to, as you said, see how we can implement the multiple things that are available to these particular two patients and extrapolate them perhaps to others. The first is Thomas, 72 years old, who came to us from another hospital with the diagnosis of a right lobe nodule as a result of his alcoholic cirrhosis. He'd stopped drinking at that point and was abstinent when he arrived to us. He had many, many different comorbidities, among them COPD requiring continuous oxygen. He also had a 6-centimeter abdominal aortic aneurysm and was on multiple medications, but surprisingly looked pretty well. He showed up in a wheelchair on nasal cannula O2, but otherwise had no complaints. So he was a Child's Pew class A6. He was ECOG 1, but maybe not really ECOG 1 because his limitations were entirely attributable to his COPD, and that would have made him a BCLC-C, but if we're going with disease-specific ECOG, perhaps that would not be the case. In any case, it turned out to not be a right lobe nodule. It's even very difficult to see on the first CT image, but there's a mild hypervascularity, which turns out to be in the back of the left lobe, so in segment 3. You can see it better On the next slide, the delayed image, so showing washout, the rapid washout that we frequently see as diagnostic of hepatocellular cancer, measured about an inch, 2.5 centimeters. So he ended up having a single 2.5 centimeter diameter tumor, multiple comorbidities, and that then left us with our decision about what to do. So I could ask you guys what you might think is an appropriate therapy for him at this point.
You know, so Matt, it seems like from the picture you paint, he was not in the best of health, given, you know, his COPD and other medical conditions. So I think the first thing is, if he did not have those other conditions with a 2.5 centimeter lesion, this is an early stage lesion, he would be otherwise somebody that we could consider for liver transplantation. But obviously, in light of his multiple medical conditions, I think would not be a transplant candidate at this time, and therefore we would otherwise consider, you know, local regional therapy options.
Well, what about if he's healthy? If he were a healthy guy with a small single tumor in an easily accessible segment, what about operation?
Yeah, I think that if he, you know, I think I didn't see the platelet count. If he did not have portal hypertension, then I think, you know, surgical resection would be our treatment of choice. But if he had portal hypertension, this would be somebody, at least in our center, that we would, you know, consider for transplant. Outside if he was not, you know, so comorbid. You know, in light of his comorbid conditions, and I assume, you know, portal hypertension, this would be somebody that we would treat locoregionally. And I think that the nice thing is, as we talked about, there are an expanding armamentarium of different treatment options that we have at this point. And so, you know, I think, as we talked about, this would be definitely somebody that we'd present in our multidisciplinary tumor board, but I think that we would consider treatment options ranging from SBRT to chemoembolization and radioembolization. I think all three of those would be, you know, options in this case.
Anything to add to that, Rich?
Yeah, interesting. I think at UCLA, like many of those in the audience, we have very talented interventional radiologists, and with a lesion under 3 centimeters, I think percutaneous ablation would be something considered. Obviously, it depends on its location. I agree with Amit that there is a tendency to do surgery for patients who are fit. The challenge, though, is they have a very high recurrence rate, right? Because we leave so much of the bad liver behind. And obviously, transplant would be a great long-term goal. But I would really defer the treatment of this lesion to my interventional radiologist, to whatever modality they see fit.
I think that's a really good point that both of you made, is there are a lot of local regional therapies available, and a lot of it's due to, it should depend upon local expertise. If you were to go to France, for example, and Thierry Henry saw this patient, he would ablate it. But it's tough. It's up at the dome, it's close to the heart, it's at the back, it's right on the capsule. It's not something that I would have considered really amenable to that. So we would have used a catheter-based therapy, and given that it's my patient, we used a catheter-based therapy. And what we chose to do is radioembolization for a variety of reasons, including the tolerability and the durability, because if you can go in and take a very large dose of radiation to a segment or two, you can get generally a very nice long-lasting result. In this case, the first picture from the arteriogram this is 2017, shows a mildly hypervascular tumor, just like you saw in the CT scan. The second image shows a later phase from the arteriogram. You can see the hypervascularity. The next picture is actually following treatment with yttrium-90, which is a positron emitter. One out of a very large number is a positron, but it's enough so you can see it on the PET, and thus we can see that we did indeed get a high dose of radiation directly to the tumor. So that was in August of 2017. This is 7 months after that. So in radioembolization, it takes a little bit longer to see the results than chemoembolization. So we generally follow chemoembolization patients right at their 1 month follow-up visit, whereas for radioembolization, we usually wait till the 3rd month. So at 3rd month, he had a complete response. It continued at his 6 months, or actually this was 6 months for that lesion, and so it was quite right around where we would have liked to have done a 6-month follow-up. So you're very exciting to see that. It was there on the past. You can now see the previous image had demonstrated some mild hypervascularity, and on the CT scan at 7 months, you can see that it's completely dead with no hypervascularity at all. That's great, but one of the problems with any local regional therapy or surgery, as you said, is recurrence. And the next slide is a lower section in an untreated area. We treated segments 2 and 3. If you look at the CT image from March 15th, much lower in the liver and the right lobe, you can see multiple hypervascular things. Hard to tell what they are, but the delayed image shows that the one in segment 6, at the back end of the right lobe, down at the bottom, segment 6, there is a hypervascular lesion that has washout. So he has developed a new tumor in segment 6, 8 months after his initial therapy. So to put his medical condition at that point in detail, he has a new primary. It measured around 3 centimeters. His AAA had not yet been treated, had grown a little bit, so he's about 6.2 centimeters now. His albumin levels had decreased from 3.4 to 2.9, so he's now a Child-Pugh B7. Still ECOG1 due to his lung problems and thus BCLC in that regard, but now a Child-Pugh B7. So in 2018, what would we do and what might we do now? And I can throw it out to you guys again.
So maybe I'll start with this one. So this gentleman is behaving like a typical liver cancer patient, right? He has bad soil, so to speak. His liver is cirrhotic, and as Amit alluded to, he's developing multifocal disease, or at least a new tumor. The other one was successfully managed. And at the same time, he's starting to decompensate a little bit. But again, in my mind, looking at this patient, I think I would still probably go with a local regional approach or interventional radiology approach, whatever that may be, to manage this tumor. I would not transition him to systemic treatment because I think he could be spared any side effects, and you guys could manage this very successfully.
Yeah, I agree completely with Rich. I mean, even though he has a new lesion, the tumor burden at this point is quite limited. He just has the one 3 centimeter lesion. Matt, as you brought up, he does have these other non-specific areas of enhancement. We don't know if those are going to blossom into HCC or not over time. But I think given his current tumor burden, this patient would definitely be treated with local regional therapy at our site as well.
And that's what we chose. And I think it's a good discussion to have. This is not did a local regional therapy and it came back fast in the same area, which is that's a different ballgame. This is a person who responded quite well to local regional therapy and now has a new tumor. So we chose to do what you suggested as well, and now we're into April, and you can see on the early arteriographic run that he has a hypervascular tumor in 6, as we saw. You can see it better defined on the late images, so it's a circular tumor in segment 6. At this point, we chose to do chemoembolization. Can't really remember why. We could have easily done a segmentectomy at that point, but I think going in, I knew that it might be fed by more than one or more segmental branch. I was concerned about the ability to treat it all at once with the Y90, and I wanted to spare as much of his residual liver as possible, so I thought I could go in and treat as little as possible, and I ended up treating segment 6. The last arteriographic run, you can see that segment 6 is gone. So that was great. His 1-month image showed a good response, as did 3, 6, and 9. And then we got something a little after 11 months after treatment, or around 11 months. And at this point, you can see it's a different sort of a game. He had his AAA fixed because he was healthy enough to undergo it. He was extraordinarily happy about that. And in the area of the first CT scan, where I'm showing on March 13th, 2019, the area where the tumors had been are gone, but now there are multiple tumors. It's difficult. It's an irregular, heterogeneously enhancing pattern in his liver to say how many, if there are more than what we called, but clearly there are multiple tumors in his liver in multiple segments. So at this point, he has progressed not just with one. At the very last CT shows perhaps the bottom of the tumor that was treated. So now we're on to the next slide that shows all of his clinical characteristics. He's developed multifocal HCC. It's almost 2 years after we first treated him. That was great, but now he has a different sort of a disease. His AAA has been treated. He's not bleeding, no evidence of varices, and his albumin levels have actually increased, so he's gotten a little bit healthier. He's now at the CPS 6 level, still ECOG1 because of his lungs, and thus BCLC. And this time he's truly at least a B, and surely looks more C-ish than he did before. So back to you guys. There are multiple options listed on the slide. Does anyone have any thoughts on what might be best?
Yeah, I think that this is clearly a different case than the last time that we talked about him developing a new lesion. I think locoregional therapy did what it was meant to do. I mean, it treated 2 lesions successfully, and it gave him, years of life that he otherwise would not have had without locoregional therapy. But this goes back to the point that Rich, mentioned when he was going through his presentation, that the natural history of HCC outside of, liver transplantation or dying from your liver disease inevitably is stage migration. And that's what we're seeing at this point, that this patient has now developed multifocal HCC by lobar, and I think that the ability of locoregional therapy to successfully treat these lesions is limited, outside of actually, also unfortunately having significant liver dysfunction that goes along with that. And so this is someone that we would definitely treat with systemic therapy at our site, and I think this is a patient where we're having increased recognition nationally, that even though this patient, as you said, Matt, falls into a BCLC B category, really is more like a C than a B. And this is where I think those prognostic scores can help in terms of saying that this person is acting more like a C than a B. So I think this is where we would definitely, once again, go back to our tumor board, heavily involve medical oncology in terms of the decisions between the different therapeutic options. And as Rich said, I mean, the nice thing is that we have many more than we used to have even just a few months ago.
Exactly right. And I would certainly turn it to Rich, but I had no interest or thought of treating him again with this. This is a different thing. What we do in our group, which involves all of the disciplines, if you treat somebody and they're doing great, then we continue to follow. But if something something untoward happens, regardless of the initial therapy, they're coming back to the board and we're talking about them, not just the initial patients, but the follow-up patients. So he immediately got presented to our multidisciplinary board upon these findings. So Rich?
Yeah, and I think both of you highlighted a keyword. This is different, right? This patient is developing a systemic disease. Even though it's just in the liver, it is systemic throughout the liver. And, before we had drugs, it'd be very tempting to go back and maybe do locoregional treatment because it's still confined in the liver. But this is different. This is not the type of disease where locoregional treatment is going to achieve long-term control. And, with the approval of Imbrave 150 regimen of Atezolizumab and Bevacizumab, I think many of us would point to this as the standard of care and first-line option for a patient who is medically fit. Obviously, they would need an endoscopy if they had not had one for 6 months, just to give us confidence that there are no varices that could bleed. But short of that, we're seeing very high response rates, very durable response rates, and prolonged survival. So I think we would all aim to treat this patient with that regimen. If for some reason they can't get that, then Sorafenib or Lenvatinib would be appropriate options as well.
Well, that was great. Thank you. That was what I was hoping to achieve, and it's good that we have, at least within the levels of understanding, I think we all are pretty much on the same page. We'll see if that holds true with patient number 2. He is a 69-year-old man. Again, came to us from another hospital. This time he had hepatitis C due to his intravenous drug use and alcohol. We believed that he has stopped the current records and was doing well other than his cough. Had, again, a history of heart disease, not as extensive as our last patient, on several drugs, none of them particularly relevant to this discussion. His labs were normal, save for decreased albumin and a markedly elevated alpha-fetoprotein at 1250. His imaging is shown in the next several slides, and what you can see is multiple irregular, poorly marginated hypervascular tumors throughout both lobes of his liver. An interesting image is a early arteriographic image, and what you can see is what appears to be a vein that has lit up in the left lobe posterior to one of the larger tumors, suggesting at least the possibility of venous involvement. And then the delayed images clearly show washout and irregular washout, as we had seen, consistent with hepatocellular cancer, diagnostic of hepatocellular cancer in a person with cirrhosis. So the CT showed us multiple hypervascular lesions. He's a Child-Pugh A6, ECOG 0, listed as BCLC-B, but at least concerning for involvement of the veins. So what would be an appropriate treatment for this patient?
So, unlike the previous patient we discussed, this patient is presenting with broad spread of his liver cancer within the liver, right? He has multiple lesions in both lobes, likely vascular invasion, and the natural history of this tumor is going to be different than someone who presents with 2 or 3 lesions on one side of the liver. And I would argue, again, this is systemic disease. And the data for the use of medication here is very strong, very high level evidence, either with the TKIs or, again, with our newer regimen of Atezolizumab and Bevacizumab of survival improvement, right? And the patient has good performance status, otherwise is up and about, good liver physiology. And this is someone who would get a distinct survival benefit from these treatments.
What if you hadn't seen any evidence of venous involvement, which I say, but we didn't call at the time?
I mean, personally, I don't think that is the game changer here, right? I mean, I don't see how local regional treatment would achieve broad disease control in both lobes that would result in a survival advantage. And like I commented earlier, the primary thing we want to achieve for this patient is improved overall survival. Certainly, maybe we could improve the scan, right, temporarily. But again, at least the picture I see from the imaging, and I defer to you as the radiologist, but he has very broad disease, multifocal disease. And this isn't a patient that I think we will easily achieve disease control with a catheter-based approach.
Yeah, I agree with Rich. So, I mean, I think the things that I'd add is, as Rich implied, for each of these trials, there's a portion of patients who fall into that BCLC-B category. So there are patients like this that are included in each of the systemic therapy trials, including SHARP and Imbrave 150. And so, I mean, there have been data, or there are data that show a benefit for these patients being treated with systemic therapy. And then, to Rich's last point in terms of the local regional therapy, although this is feasible, even if there weren't vascular invasion, to do local regional therapy, it would be almost definitely associated with a decline in liver function. And so the fact that this is bilobar, multifocal, I think it would be, diffuse treatment. It would not be selective, and I think that inevitably would be associated with liver dysfunction, and I think unlikely to improve the survival as much as systemic therapy.
And that's why I included this case rather than a straightforward 2 or 3 very well-defined hypervascular tumors. When we had the advantage of having a trial for radioembolization plus an immunotherapeutic agent, and so we enrolled him in that because I believe in the benefit for this wide advance as well from the systemic. So I can't really argue. I think that there is a difference between this and BCL, straightforward, easily treatable, apparently, BCLC-B disease.
Yeah, that's a great point, Matt, because there is an interest now in moving these new systemic agents into the earlier stage setting, right? And the challenge with that has been that there are many patients with Barcelona B intermediate who do very well with local regional treatment, right? And they have a very long survival. But to borrow a term from Dr. Salem at Northwestern, there's that high risk B, right? Whether it's up to 7 or beyond 7, or Amit talked about some other staging paradigms that can predict how patients do with local regional treatment. This is a patient who technically is B, but is a high risk B, and would be a great candidate for this type of combined approach in the context of a clinical trial.
Right, and there are many of those clinical trials either in progress or gearing up. So I'm looking forward to those combination local regional therapy, immunologic and TKI combination trials as well.
I think this is really where the field is going, is not to have discrete therapies, but really combination therapies where we can take advantage of both of these working together.
And there's rationale for that. There's been studies that have shown that with destructive therapies, whether ablation or chemoembolization, that there's antigen release. And one of the proposed mechanisms to combine this with checkpoint inhibitors is to activate the immune system against these new antigens. And there's been description of what's called the abscopal effect, where we see systemic responses, meaning after chemoembolization, we start seeing responses with the combinations in the lung or other sites. So there are a lot of ongoing studies that are looking at this combination of local regional therapy with checkpoint inhibitors, and those are highlighted here. And this includes not only intermediate stage with a number of the drugs we had spoken about, but also now including these in a true adjuvant setting, right? One of the issues with TACE studies is, do you do it in combination with TACE, before TACE, sequential with TACE? But in the surgical early stage patients, and these often include patients who have resection and have high risk features at explant or at resection, or even patients who have high risk RFA. So larger tumors or multiple tumors that get RFA, and then they're typically being randomized to adjuvant regimens with checkpoint inhibitors to see if we decrease the incidence of recurrence. So an area of very active research. And again, regardless of the case, I think we still will all maintain that clinical trials are often the best option for our patients, regardless of stage, if available.
That was great. I think we did a nice job of encapsulating the current status of the treatment of people with hepatocellular cancer. It's important to emphasize throughout and again the necessity of multidisciplinary cooperation, because none of us is an expert in everything, and we need to trust our colleagues. And we all want to do what's best for our patients, and doing it together has been shown and is clearly the right thing to do. So thank you very much for your attendance, and thank you, Amit and Rich, for joining me today.
Thanks, Matt. It was great to be here.
Yeah, thanks a lot. It's been great to be part of this multidisciplinary program.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DWV860. This activity is supported by educational grants from ASI Incorporated, Genentech, and Merck & Company Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.